Good morning and welcome to our HIV Prevention and Education Virtual Summit pre-recorded presentation entitled Current HIV Research Delivered in Collaboration Between Community Advisory Boards and HIV Researchers. This video was provided by research collaborators from Wistar and Penn Medicine. Before we begin, I'd like to go over a few reminders. Viewers, please make sure your mics are muted. The chat box is disabled, but you can ask questions using the Q&A box located at the bottom of your screen. Remember, this presentation is being recorded. Q&A will take place at the end of the presentation. At this time, I will turn it over to our panelists so that we can begin the presentation. Thank you.
Welcome, everyone. This is Annette Davis from the University of Pennsylvania, and I am proud to welcome you all to the presentation that, thank you. I'm sorry, I was stumbling. I was waiting for the video to come on. So again, thank you all for joining us today for the current HIV research delivered in collaboration between community advisory boards and HIV researchers panel. As mentioned, many of the recordings are recorded, but number of us will be available to participate in the discussion afterwards. So with moving forward, I'd like to start our presentation, and thank you again for joining us.
Good afternoon, everyone. My name is Naima Sanchez. I use she, her pronouns, and I am the HIV Clinical Trials Unit Community Advisory Board Chair. The University of Pennsylvania HIV Clinical Trials Unit Community Advisory Board is a bridge between the communities impacted by HIV/AIDS and the research staff. The University of Pennsylvania Clinical Trials Unit Community Advisory Board acts as an ongoing forum to actively engage community and to advise about the clinical trials unit research studies. Community involvement contributes to the success of the studies at the clinical trials unit and is driving us towards a day where we will eradicate HIV in our communities. Now you will hear from Dr. Ian Frank, one of our principal investigators for our Prevention Clinical Trials Unit, and he will provide you with information regarding new PrEP modality and HIV vaccine research.
Hi, everybody. I'm Ian Frank from the University of Pennsylvania, and I'm talking to you representing the Penn Prevention Unit. And I'm going to talk to you today about advances in HIV prevention, recent advances, and the key role that the community has played in these advances. So I'm going to talk about three different things. First, PrEP. So you know that we have now three different medications approved by the FDA for PrEP use. We've got two forms of tenofovir, emtricitabine, in Truvada and Descovy. And now we have injectable cabotegravir, a drug called Apretude. So let me tell you about the work that we've done and the community in Philadelphia has participated in to lead to the FDA approval of Apretude. And the key study is this trial, the HIV Prevention Trial Unit 083. So here's the design of that study. People who are at some risk for HIV acquisition start on one of two pills. This is a placebo-controlled trial, so we don't know what intervention people are getting. And they start by taking a cabotegravir pill, or they start by taking tenofovir emtricitabine pill. One of them is real, one of them is placebo. And then if people tolerate the medication, they then switch over to either continue on the real pill, which is now just tenofovir, or a placebo pill, or they get injectable cabotegravir or a placebo injection. And they get these injections every 2 months, and people continue in the study for a 3-year period of time. There was a similar study that was done outside the United States in Southern Africa for cisgender women. This study, done in the Americas, in Africa, and in Asia, were for cisgender men who have sex with men and transgender persons. So here are the sites where this work took place. You can see most of the sites were in the United States. There were some in South Africa, one site in South Africa, several sites in South America, and a few sites in Southeast Asia. And our Penn Prevention Unit was the second highest enrolling site in the United States. We're very proud of that. And we're grateful to you, the community, for making that possible. I want to highlight some of the characteristics of the study population because there are some really unique features here of the population. So trans women, 12.4% of the population in this study were transgender women. That's the highest proportion of trans women enrolled in an HIV prevention study to date. Another key feature was this was a study that included mostly young individuals. 2/3 of the cohort were 18 to 29. And if we look at the racial demographics, about half of the participants were Black or African American. So this was a very diverse study, and the results are applicable for every group of participants that were enrolled, either from a racial or ethnic perspective, or also from a gender perspective. And here was the bottom line for this study. If you look at the graphic on the left-hand side, you see there were 13 infections in the group that got cabotegravir. It was less than 1 infection per 100 person years of observation. So if we follow 100 people for a year, less than 1 of those individuals became infected. If we look at the infection rate in the group that got tenofovir emtricitabine, this is the Truvada formulation, it was a little bit more than 1 infection per 100 person years of observation. So the injectable cabotegravir decreased the risk for HIV acquisition by 66% compared to the pill. And this was the key study that showed that a long-acting injectable form of PrEP is more effective than taking a pill every day to prevent HIV acquisition. So what do folks need to understand about injectable cabotegravir for PrEP? So first, injections need to be given in a provider's office. They can't be given in a pharmacy. And the reason for that is the injections are given in the buttocks, in the behind, in the middle of the behind, and it has to be administered with a certain kind of injection technique so that the cabotegravir does not drip out of the hole made by the injection. The injections are given every 2 months. And in rare cases, even when people are getting the injections at the appropriate interval, there are cases where some people have still become infected with HIV. And the real concern there isn't just that they got HIV infected. Obviously, that's not what we want to see happen. But it's also possible that people who get infected while taking the injections, the virus that has infected them can become resistant to the integrase inhibitor class of drugs, including dolutegravir, that's the drug that's in Tivicay or Dovato, or bictegravir, which is the drug that's in Biktarvy. And these are the drugs that we most like to use to treat people who have HIV. So if someone gets infected on cabotegravir, those medications may not be effective, and we may need to treat people with other medications. Also, if somebody becomes infected with HIV while on injectable cabotegravir, it may take a while for their antibody test to become positive. And for that reason, people need to be monitored with a viral load test, which can be more sensitive than the antibody test if somebody becomes infected. And they need to be tested with a viral load test every 2 months at the time that they get their injection. What people also need to understand is that cabotegravir lasts a long time after it's injected. And so if somebody says, I don't want a shot anymore, they need to be switched over to oral PrEP and get tenofovir emtricitabine while the cabotegravir is still in their system. Also, in that study, injectable cabotegravir worked just as well for trans women as for cisgender MSM. So we know that for a fact. And in the sister study that I referred to earlier, we know that cabotegravir works just as well for cisgender women as it does for cisgender MSM. So a very effective strategy, but something that may not be appropriate for everybody. So we may need other types of HIV prevention. And there was another big study that we participated in where we've seen the results in this past year, a study of neutralizing antibodies for HIV prevention. So these are antibodies that are cloned from individuals who have HIV, but antibodies that are good at controlling HIV replication, not in those individuals who became infected, but these antibodies prevent virus replication against the types of virus that cause infection, new infection in HIV uninfected individuals. Again, there were 2 big studies that were done. They're called the AMP trials, and they were organized through the HIV Vaccine Trial Network and the HIV Prevention Trial Network. One study done in the Americas and Europe that focused on men who have sex with men and transgender folks, and then a study done in sub-Saharan Africa that focused on cisgender women. And the studies were designed in the exact same way. Individuals got this one particular antibody called VRC01 at one of 2 different doses. And the antibody was administered through an intravenous infusion every 2 months. So again, something that requires an intervention in a provider's office. This is not something that's FDA approved at this point in time. This was a proof of concept study to see if this kind of approach could be effective in preventing individuals from becoming HIV infected. We participated in the study. Again, we were very successful at enrolling people. We were the highest enrolling site in the United States. Before the study started, we had a dinner. We invited a number of community representatives who were really key in giving us very helpful advice about how to effectively recruit individuals into this study at our site. And I just want to emphasize that the community really played a key role in our success, and we're very appreciative of the advice that you shared with us. And here's the bottom line from this study. The BNAbs, the broadly neutralizing antibody, it worked. But it only worked against virus that was really sensitive to the antibody. And in the community, there was a lot of virus that was circulating, some of which was sensitive to the antibody and some of it which was more resistant. And so the antibody worked against the virus that it was sensitive to, but more resistant virus that was in the community, the antibody did not work to prevent infection with that more resistant virus. Now, the good news here is that if somebody gets infected with that more resistant virus, that virus is resistant to the antibody, but not resistant to the drugs that we would like to use to treat people. So people still had the opportunity to be treated with any of the drugs we would like to choose. I don't really mean to say that that's good news, but it's not doubly bad news that they're infected with virus that's resistant to the drugs that we would like to use to treat them. So obviously there's a lot more work that needs to be done before this kind of strategy could be used, and antibodies are being developed that are more effective than the one that was used in the study. And the antibodies are being modified so they could be injected under the skin and perhaps with intervals of 3 months or maybe even longer. And we're starting to study combinations of these modified antibodies. And maybe in the next couple of years, we'll see a large preventative study where we're testing 3 combinations of long-acting antibodies, and we'll see if that kind of strategy will work. So this is something not yet ready for prime time, but one where there's still a lot of optimism. And lastly, I want to talk about HIV vaccines. So why do we need a vaccine when we have PrEP that's so effective? Well, PrEP can cause side effects. As I said earlier, if somebody becomes infected while on PrEP, the virus that's infected them may become resistant to the PrEP medication. And PrEP is expensive. So vaccines are a traditional way we prevent individuals from becoming infected with infectious agents. It's the least expensive form of biomedical prevention. So we would love to have an effective vaccine. And if we had an effective vaccine, it's not a one choice kind of proposition. It's not an either or. People can get a vaccine and take PrEP as well, and perhaps make the preventative combination even more effective. So we've got one large ongoing preventative HIV vaccine trial called Mosaico. We're participating in that study. It's being sponsored by the HIV Vaccine Trial Network. We were successful in enrolling into this study too. Again, we're grateful to the participants who've elected to enroll in the trial. To date, we don't have a vaccine that has shown to be effective at any level where we would like to pursue that particular vaccine product. So the vaccine that we're studying in Mosaico is a unique vaccine, and we'll see whether or not that particular product will be effective. But we have a whole host of new vaccines that we're testing in what we call early phase trials, where we're seeing what kind of immune response people are making. And these include mRNA vaccines that have shown to be effective against COVID-19, and other technologies that are far more promising than the older vaccines that we've studied to date. And we need volunteers to participate in these early phase studies too. So we can't do this work without you. We're in this for the long haul. We want to develop interventions that can protect people from becoming HIV infected. It's our mission. It's our life's work. And we're grateful to you and to our allies who've been willing to participate in the work. We appreciate the generosity of your spirit and your courage for being willing to participate in this work. We know it's an experiment to some extent. We know that there are risks involved. And again, we appreciate your willingness to travel down this path with us. So thank you very much.
Good afternoon, all. Welcome to the Beat HIV Cure Collaboratory, part of the All CAB workshop. I am William B. Carter, chairman of the Beat HIV CAB, our Community Advisory Board. I'd like to acknowledge and thank our principal PIs, which is Dr. Louise Montanier, Dr. James Riley, and Dr. Robert Silicano. And also we would like to recognize Dr. David Metzger, our Community Advisory Board Facility Director. The CABE operates as an expanded model of community engagement, which is part of one, Research Sciences Cure-Directed Agenda, also Community Advisory Board, which is people living with long-term HIV and AIDS, also advocates to represent the community's voices, which I am the chair of, and also community-based organization, which offers professional service groups, which happens to be Philadelphia Fight. Now I would like to turn it over to Dr. Montanier, who would speak to you on the things that we have going on at the Beat HIV. Thank you very much.
Thank you, Will, and thank you everyone for joining us today. So what I want to do is sort of take you through some of our research activity and also highlight the KEG accomplishments for which we're very thankful for Will and everyone in the CAB who contributes to this program. So let's get started. The Beat HIV is one of 10 such collaboratories in the United States, and it's one that is a renewed group that is now able to move forward into the next cycle with the benefits of having established a strong working group moving forward towards a cure. It is a large coalition of over 100 faculty and community members representing 41 institutions and 10 industry partners. And what's exciting is that this is really a global community effort that encompasses really multiple perspectives and efforts around the globe. Our group is really centered on 4 main activities that are targeted towards understanding the reservoir and what may determine the persistence of HIV, and most importantly, developing strategies to either control rebound after stopping antiretroviral therapy or achieve a level of reduction in the reservoir that could be a direction towards eradication. And importantly, these, as well as an enhancement of social science efforts, need to be done in the presence of community participation. Now, from a point of view of trying to summarize this in perhaps in a cartoon fashion that I find really quite useful, these 3 themes are reflected here again, which is that pursuit to try to understand where the reservoir is and how to get to it, the efforts to strengthen your immune system in order to control the virus without antiretroviral therapy, or the efforts to really eradicate or take out cells that are infected with HIV and remain persistent, and as a consequence, really just eradicate the presence of the virus from the human body. Now, the continuum of this effort really is could be seen in this summary, which is really taking our ideas from concept development all the way towards a clinical trial effort. And to do that in the communication with community members, which we would otherwise refer to as community engagement. So we want, I think, in this second cycle to really support this continuum of strategies that hopefully will be tested within the next cycle of the Beat HIV Collaboratory. So let's talk about some of the research highlights that we're trying to accomplish. And as I mentioned, we could really focus it on three research objectives. The first one being mechanism of persistence, or how to find the virus. And I think it is important to perhaps confirm that we're still really chasing an observation from 1997, which was really after the onset of antiretroviral therapy. The expectation was that we would treat, and like penicillin is to bacteria, the virus would eventually be restricted from persisting and the body would clear the viral infection after successfully having blocked the ability of the virus to replicate as measured in the blood. But that did not happen, in that this observation really reflected the fact that the virus remains stable, and it remains in a person living with HIV, requiring the continual suppression by antiretroviral therapy. So since then, efforts continue to try to change this dynamic, to determine how can we chip away at the persistent HIV to make sure that we can accelerate this decay, that we can make this line take us to eradication. And we've learned a lot about how to measure the virus in a person living with HIV. And I think today we have not only identified which type of persistent HIV we need to be measuring, that otherwise we refer to it as an intact copy, because it is really less than 1% of the reservoir that is intact. But I think the efforts now are that within that 1%, we need to understand which measurement can best reflect the virus that would rebound after you stop antiretroviral therapy. So studies such as this one, which is basically reflecting an analysis of a reservoir by multiple parameters, is where the field is today. And let me summarize that another way, which is really, if you take it from the top, we started by measuring the total amount of HIV that we could detect in the blood. As I mentioned, the second line reflects being able to take that to the 1% of virus that is intact and could potentially make a copy of HIV. And we now are in the next line, which is really within that 1%, which intact copy is able to actually be read. And of those intact copies that could be read, which ones are actually actively repressed and from being expressed. Because, for example, if we want to reactivate the virus to clear it, we're going to have to remove that repression, even if it sits in a site of the gene that could be read. And then lastly, how do we induce immune responses to go after that specific component of the 1%? And I think that's where we are today. Now, obviously, apart from understanding the anatomy of HIV, we also want to understand why does the immune system doesn't clear it? And what can we learn about the cells that have HIV to make us go after it more efficiently? And studies such as this that the collaboratory has recently reported provide new insights into how HIV may persist. And let me take you through this in a cartoon fashion, which is that we all have these cells that can kill HIV-infected cells. We call them cytotoxic CD8 T cells. And what these cells can do is they can go find and kill infected cells. And they kill through the use of a particular protein called granzyme B, among others. And the reason that granzyme B doesn't kill the CD8 T cell is that the CD8 T cell kind of protects itself with another protein called serpin B9. So that's fine. The CD8 goes and kills and doesn't get killed itself. It has serpin B9, everything is good. The problem starts because there are CD4 cells that can also have the same function. And the problem with that is that HIV can infect a CD4 T cell. So now you have a scenario where if the CD4 cell that can kill is trying to expand itself to control a viral infected cell that, against, say, CMV, it doesn't have to be HIV, and it's actually expanding to control that CMV infected cell, but it actually happens to be infected with HIV at the same time. So now the HIV is expanding as the CD4 is trying to control another infection. And now the CD8s get wind of this and they go, wait a minute, we have to go and get rid of the CD4 T cell as well, because that is virally infected. But because of the shield that these cells carry, such as serpin B9, they're not killed. And now they can expand and contribute to the persistence of HIV in spite of the immune response and in spite of antiretroviral therapy. So this was just reported. This is March of this year, but once we know about it, we can develop strategies to try to intercede and change the dynamic that you're seeing here. Another area that we're very interested to understand is what determines the amount of virus that returns in the blood after somebody stops antiretroviral therapy. And we have studied a lot of factors that may contribute to this, such as host responses or antibodies, or the type of scenario that I just described to you as an immune system response against an infection, that the expansion of the reservoir could be kind of a secondary effect of the infection of the CD4 killer cells. But we're also interested to now determine the potential for new molecules in the blood that have not yet, that were recently identified, and before we didn't know about them, and that could also contribute to the level of control. And the benefit of this particular aspect is that then we can potentially use these molecules as intervention, because if we see it that a molecule can accelerate the expression of virus, or if we see that a molecule in the blood can prevent it, then that gives us tools to perhaps intervene with these as therapy. And that's also underway in the collaboratory. So as far as strategies for suppression, we have a lot under development. We have upwards of 6 different strategies that are being developed by different components of our team. And in addition to this, we also have a particular emphasis around the use of antibodies and the modulation of cells such as the natural killer cell, which is a cell that we all possess and could be used for early antiviral responses, in addition to how to improve our T cell responses by new therapeutic agents that can find the virus more efficiently. Now, the use of antibodies is something that we have been working for some time, because we and others in the group have been really excited about the prospect of broadly neutralizing antibodies as novel therapeutics that can suppress HIV, even in the absence of antiretroviral therapy. And recently, members of the team in Rockefeller, under the leadership of Dr. Nussensweig, reported that these two antibodies could replace antiretroviral therapy and suppress virus for upwards of 6 months. Now, the interesting thing is that we use exactly the same two antibodies, but here in Philadelphia, we tested them with a third agent at the same time, and one that can stimulate the immune system directly. This is called interferon alpha 2B. So now we have the report of the New York team that's also in the collaboratory on the use of the antibodies to suppress and maintain the virus under control. And now we're analyzing data by that same strategy, but with a molecule that can actually enhance clearance. And the question is, what's going to happen? So we're currently analyzing this data, and we're really thankful to the contribution of 14 individuals in our community that participated in this study. And this study now allows us to almost learn from the New York experience, because our study is exactly the same as theirs, but we've added a third component. And I think that we have recently documented that during the period of immunotherapy and after, we can follow outcomes of what this therapy has meant. The first piece is that during the period of immunotherapy, control was achieved. Like in the New York team study, we're also documenting that suppression was achieved in upwards of 83% of people. So this is important because it's saying that at least two independent studies are having the same result, which gives us greater confidence that these antibodies potentially could be developed as therapeutics. The next question is, what happens to the virus after the exposure to these agents in people that are maintaining suppression with this immunotherapy strategy? So we've been able to document that of the 10 people that were able to stop antiretroviral therapy, 4 of them did not meet the retreatment criteria of the study by 3 months into the study. And at 6 months of the study, there were 2 individuals that continued to not meet criteria. And interestingly, they started to show a profile of expression of virus and then control. And this has been actually maintained to the point that one of our participants is still off therapy, even though they started this quote unquote period after immunotherapy since April of last year, and they still remain off antiretroviral therapy. Now, the patterns that these individuals show is one that we have seen in others before, which is we call them post-treatment controllers. But in contrast to the post-treatment controllers that just stop therapy, and this is the pattern that they show in blue, these 2 individuals are post-intervention controllers because we've introduced an intervention, not just antiretroviral therapy. And they're very different than the experience of people when they stop therapy, which is the black of this sort of high virus without subsequent control. So we want to understand these individuals further, and this is a component of our effort at this time. Regarding eradication, I don't have time to review all the strategies, but we're pursuing strategies that include gene therapy of T cells, as well as using the mRNA technologies for removal of co-receptors, taking the leadership from teams such as the University of Pennsylvania investigators that contributed to the mRNA vaccines that we currently use in COVID. So we're very excited about the prospects of this moving forward. From a community engagement, we have an active contribution of multiple means of education by videos that are available at our website, beathiv.org, as well as a position paper that we have worked with the community to generate to address multiple aspects of cure-directed research, as well as a Bill of Rights and Responsibilities guiding our research even today. Most recently, we've contributed to the use of a device for viral load measurements at home. And we've tried to analyze and understand these devices from the point of view of both how well can it measure viral load and how well can it be accepted and used by the community. While the measurements of viral load are currently being evaluated now, we did already complete studies on community acceptability as well as national surveys on the concept of this device for use that have been recently reported. And this is all part of an overall emphasis on socio-behavioral sciences that the Beat HIV Collaboratory is moving forward with. Now, lastly, I would like to invite everyone to the 26th Annual Jonathan Lax Lecture, which you can register at this site, where we're going to be hosting Dr. McCune, that directs the Gates Foundation HIV cure effort, as well as we're going to have a forum with cure advocates in people that want to move the agenda within distinct regions in the world, both US and Africa, in trying to get different perspectives of what the cure means to them. And we're really thankful to have multiple organizations across the globe that are going to be contributing and as sponsors to this activity. So if you want to get involved and you are a person living with HIV, owner of art, and want to provide biological specimens, we learned a lot from these regarding how to measure persistent HIV. If you are a person living with HIV on medications of substance use disorder, we also have an interest to understand how these medications may affect the persistent HIV in together with the use of antiretroviral therapy. And of course, you can join our community advisory board and represent people like yourself and your community within the overall group. If you want to pursue and get involved, I welcome you to contact Ken Lin. And here is his cell number and his email, as well as either reach out to me or Will, who would put you in touch with Ken and take it from there. So I want to thank all the participants that contribute to this work, and you, the audience, for learning about our research. I want to thank all our members in the collaboratory, and of course, our funders that make this possible. So thank you very much.
Good afternoon, everyone. My name is Lori Corbin. I'm Managing Director for Community Engagement from Public Health Management Corporation, and I serve as Chair for the PMARC CAB. PMARC CAB, the Penn Mental Health AIDS Research Center, actually works to do research in the community related to HIV, AIDS, and mental health. Members of the CAB represent either themselves as individuals with lived experience and or friends or family members who have lived experience with both mental health and or AIDS. I'm pleased to introduce Michael Blank, one of the researchers from the center, who will tell you more about a project to help support the community to access resources in the event of family members having a mental health crisis in the community. Again, Michael Blank is one of our researchers who helps support the PMARC CAB, and I'm pleased to introduce him today. Thank you so much for your attendance at this presentation today.
Okay. I'm Michael Blank. I'm a professor of psychology in psychiatry at the University of Pennsylvania. I'm a community psychologist. And among the things that I do, I co-direct the Penn Mental Health and AIDS Research Center, which is funded by NIMH. And we're really the first center that focuses on the comorbidities of people with mental illness and HIV and the complex and recursive interaction that occurs between those conditions. So people with mental illnesses are at much higher risk for contracting HIV. And as well, people with HIV are at much higher risk of developing a mental illness. So we focus on that complex and recursive interactions. So one of my tasks as part of the Penn Mental Health and AIDS Research Center, we call it PMARC, is to direct the community engagement core. And what we envision is that we want to have a bi-directional relationship with the Philadelphia community. There are a number of different community advisory boards associated with HIV at Penn, and I'm involved with at least 3 of them. What we have found over time is it's critical for us to engage advocates from the community in our centers. And the way that we do that is by having a bi-directional relationship. Not only do we want the community advocates to represent the research that's done at PMARC favorably to their community partners, but also to bring research ideas and concerns from the community to the PMARC researchers. So the CAB is a self-directed entity, and it has a small budget, with which it can do anything that it likes, basically. And with that, I'm going to read the mission statement of the CAB. And their mission is to promote the mental health of people living with HIV infection and AIDS through research, evidence-based treatments, and education. The CAB will foster communications and partnerships among affected individuals, advocacy and provider organizations, and researchers, and will help guide the PMAC research agenda. Next slide, please. CAB membership is determined by the person's involvements and commitments to providing the health of people living with HIV and mental health issues. We are community leaders, community teachers living with HIV, living with mental illness, living with hepatitis C. They're caretakers, activists, public health advocates, LGBT people, formerly homeless, domestic violence survivors, cancer survivors, cancer fighters, therapists, researchers, clinicians, and social workers. This represents the community footprint of the CAB. Now, these people come from lots of different community organizations. Now, they don't represent their organizations per se, but they are involved with very many of them. So one of the things that I wanted to chat briefly about was the Magnet Project. So the CAB puts on an annual Connecting the Dots symposium, which provides education about HIV and mental health comorbidities to frontline mental health workers. What happened was right after the Connecting the Dots symposium took place, there was a shooting of a man named Walter Wallace by the Philadelphia Police Department. And it was featured prominently in the national news. One of the CAB members represented the mental health center that Mr. Wallace was receiving treatment in. And the reason this made the national news because he was shot and killed by the police in front of his family, who had called 911, but because he was having an acute emergency. And he was wielding a knife. However, the police, despite the fact that they had been issued funding to buy every police officer in the city a taser, none of them had any non-lethal means of intervention. So he was shot and killed. The PMARC CAB, in recognition of the unfortunate shooting death of Walter Wallace, in collaboration with the consortium, which is the mental health center that Mr. Wallace was receiving treatment from, and the Department of Behavioral Health and Disability Services created and produced 50,000 magnets and brochures that are now being distributed throughout the city of Philadelphia to provide alternative resources for individuals and families in the event of a mental health crisis. We wanted to advertise that there is already an existing crisis line that, rather than calling the police and 911, to call this crisis line in the case of a mental health emergency. This has worked so well. It's hard to believe. We have made enough of these refrigerator magnets that we intend to be able to distribute it to the families of every severely mentally ill person in the city of Philadelphia. So, motivation and momentum. The Community Advisory Board is deeply committed to each other and to the community. Distribution of the magnets and brochures have occurred at the members' organization, at community events, health centers, and academic events. The distribution has occurred on a very large scale, and as well as on a smaller scale by the CAB coordinators and each of the Community Advisory Board members. The Magnet Project grew out of the motivation of the CAB to source information and services that they felt were desperately needed, and to hopefully invoke change within the Philadelphia community in response. It's a little early to tell because all of the magnets have not been distributed yet. However, we already have noticed that when people call 911, the dispatchers now ask if this is a mental health emergency. And they have the capacity now, rather than directing the call to police, but to direct the call to one of 4 crisis intervention teams. They're available 24 hours, and they are able to provide services throughout the city. So these are the organizations that have been involved with the Magnet Project. And I just wanted to draw your attention to what I see as an exemplar of how Penn can work with the larger community in Philadelphia to deliver needed services. Thank you very much.
Hello, my name is Daphne Robinson, and I am the chair of the University of Pennsylvania Center for AIDS Research Community Advisory Board. Our mission is to foster and maintain partnerships and open communication among community members and HIV researchers, and to enhance HIV education, prevention, and treatment research activities reflecting both the needs and interests of the community and Penn investigators. So essentially, we pull together a host of various stakeholders that have a true drive and heart for the work around HIV. There exists between the Community Advisory Board and the researcher a bond where we work together collectively to make sure that the community voice is heard, so that those who are often forgotten have a place in research around HIV. At this time, I would like to introduce to you Dr. David Mesker, the director of the HIV Prevention Research Division. Thank you.
All right, everyone, we're going to get started with Q&A in just a moment. I just have to promote panelists so that we can begin Q&A. Give me one moment, please. Hello. All right. Will
I think
Dr.
before,
Blank be joining us today? Dr. Michael Blank?
I don't think so.
Okay, then wonderful. So does this look like the correct group? Should I be waiting on anyone else?
I don't think so.
Oh, okay, wonderful. Well, thank you all. And we can begin Q&A.
Actually, before we begin the Q&A, I'm wondering if I could make a few comments. Daiquiri just introduced me, and I would like to just say a few words about the coordination of all of these community engagement efforts.
Of course, yeah, you have the floor.
Right. Well, the CFAR CAB was started 19 years ago in 2003, with the mission of trying to provide a bridge to the community for investigators working in HIV research at the University of Pennsylvania, at the Wistar Institute, and at CHOP. Its mission is broad because of the array of research that's going on, focused on HIV, ranging from laboratory basic science research to mobile health applications. But the CFAR CAB has been meeting on a monthly basis for the last 19 years, and has contributed to the establishment of several of the other CABs that have presented here today. The BEAT HIV CAB, the CTU CAB, and the PMARC CAB. So I just want to thank all of our CAB members, which total over 60 people collectively, who meet again on a monthly basis and work hard to plan activities, meetings, and community events to promote awareness of HIV and awareness and support for the research that's directed at HIV prevention and treatment. I think it's now become, it hasn't always been, but it's now become a requirement for communities to be involved in NIH-funded research, primarily through the community advisory boards. And this is because it's now quite obvious to all of us and to all of our funders that effective HIV prevention and treatment strategies won't go very far unless they're perceived by the community as acceptable, and unless they're accessible and affordable. And there needs to be, and the recognition now is that there needs to be a significant investment of effort to make sure that communities are aware of the status of our research efforts and understand and have access to the investigators who are leading these research enterprises, and to develop and promote support for them. We've learned a lot in the last 2 years as a result of COVID. The pandemic, I think, has demonstrated the importance of trust in science. We've had, on the one hand, a remarkable success with developing an effective and safe vaccine against COVID, largely because of the HIV research infrastructure that was in place prior to COVID becoming an issue. However, we also saw that many people did not trust the science. They didn't want to take the vaccine, and it was easily distorted the importance of this vaccine was easily distorted by political forces. So it's just a reminder of the ongoing challenge of community engagement and the importance for our science to be effective. Community needs to be a partner in the research from its inception. And so once again, I just want to thank all of our community advisory board members, and I look forward to continuing our work together and to developing more effective strategies for community engagement. Thanks very much. And I think we can now begin the Q&A.
Thank you, Dr. Metzger. At this time, we don't have any questions. To our attendees, please take the next moment to add Q&A into the Q&A box located at the bottom of your screen. We'll just take a minute to see if anyone has any questions or would like any add any comments about the presentation. Thank you.
Hi, this is Annette Davis. I don't have a question, but I also wanted to thank all of the CAB chairs who introduced each of the principal investigators and researchers for each of the various CABs. And I encourage anyone who is attending today's session to please reach out and contact us about joining any of the community advisory boards that were presented today, because as Dr. Metzger just shared, that in order to have our research agendas successful, we really need community input and community involvement. So thank you. And thank you all for presenting today.
Thank you, Annette. We have, first we have a comment that says, great presentations, learned so much. William Carter would like to say, I'd like to invite to BHV next meeting. And Jennifer saying, trying to develop trust in science is very insightful and is definitely a challenge today. Yes, agreed. If everyone would like to take another moment, if you have any questions or any comments, please do so. Go ahead and add it to the Q&A box. We can share the CAB coordinator email addresses if anyone would like more information about joining any of the CABs. Thank you, Amy. All right. Thank you, William. Being involved is the greatest thing to have input. Exactly. Thank you to our panelists for your thoughtful and insightful presentation, and thank you to all of our viewers for joining us today. And please join us for all of our upcoming presentations. Like Amy said, we can share the CAB coordinator email addresses if anyone would like more information about joining any of the CABs. We have one more comment. In my profession, I supervise individuals who have HIV. What is the best way to refer them to this service? Would anyone like to go ahead and answer that question?
Well, I think what was just mentioned by, if we can share the contact information for any of us, we can direct them to the CAB that's most appropriate or that they're most interested in.
Wonderful.
I would say also there's this Friday, the new collaboratory at Temple, the CRISPR for Cure CAB is hosting a community event at the Free Library from 1 o'clock to 4 o'clock. And all community members are invited to attend to learn more about the CRISPR for Cure mission, and the other CABs that were mentioned here will also be present, and the research will be, and some of the investigators will be present as well.
Wonderful. Thank you so much. And I just mentioned to Amy that for everyone who attended today as an attendee, we have your emails. So any of the information that is shared with us, we can send to you via email. Wonderful. All right, panelists, any last words before we go ahead and end this presentation? Awesome. Thank you, everyone. Take care, be safe, and have a wonderful day.
Thanks.